I cordially invite the chairpersons for the next session, Dr. Manjula Vijayawardena and Dr. Kalana Parna Palyaguruge. So let's continue on with our next presentation, Population Screening for Kidney Cancer, Madness or Brilliance, by British Journal of Urology International. Over to the moderators to introduce the speaker.
Grant, before you start, I'll introduce you formally. Professor Grant Stewert is a professor of surgical oncology at University of Cambridge, and he is an honorary consultant in urology at Addenbrooke's Hospital, UK. He is here as the BJUI Lecturer for this year's celebration. He has been selected by the BJUI Board of Governors for this historic occasion. He brings greetings of the BJU International to our meeting. Over to you, Grant.
Great, thank you very much. It's a great pleasure to be here. Thank you for the invitation. So I bring greetings from Cambridge in the United Kingdom. So I'm delighted to be a professor at this fantastic 800-year-old university where we're able to do great collaborative research and work clinically just a couple of miles down the road at Addenbrooke's Hospital. This is the Cambridge Biomedical Campus, which is the largest biomedical campus in Europe. And if you're in the UK, please do come and visit us. We'd love to host you. So I'm going to be talking to you about kidney cancer in the UK, and what we're doing to try and improve outcomes from this disease. So to set the scene, kidney cancer is the 6th commonest cancer in the UK. It's the most lethal of the urological cancers. Of all of the patients that present to our clinics, unfortunately 48% will die of the disease if they have kidney cancer. Of the 5 cancers that are more common, it's only lung cancer with its terrible 10-year survival of 5% that has a worse outcome. So it's a lethal cancer. It's a cancer that is an increasing public health problem. So it's one of very few cancers that's projected to increase in its incidence over the next decade. Most cancers are plateauing or reducing in their incidence. And of course, as you will know, it is generally a silent disease at a curable stage. So overall, all patients that present with kidney cancer, only 40% will have card-carrying symptoms such as hematuria. But if we look at those patients who have small renal cancers of 4 centimeters or less, that drops to around about only 10% having symptoms. As you know, all roads lead to a CT scan, and then on to the discussion about the multiple different treatments that we can offer these patients, be it surveillance, be it ablation, or as you see in this video, robotic partial nephrectomy. So we've made advances in the treatment of kidney cancer over the last decade, both in the localized setting, but also in the more advanced setting with the drug treatments. But have we improved outcomes? Well, have a look at this data, which tells us about age-standardized mortality rates and how they've changed over the last 50 years. And if you look at this column here, you can see for all cancer types, there's been a 27% improvement in cancer outcomes over that 50-year period. For prostate cancer, there's been a 39% improvement in survival. For bladder cancer, it's right on the money at 27%. But for kidney cancer, the survival improvement has been lower. It's only a 4% improvement. So how can we improve outcomes from kidney cancer? Well, I have biases around this because these are the 2 areas that I research. But one is to treat high-risk localized disease better by using not only surgery, but drug treatment before surgery and after surgery, or to detect disease early. Early detection of cancer is a major focus of our English National Health Service. For us as clinicians and for our patients, it allows diagnosis at a curable stage and hopefully a one-off treatment. But actually, it is also much, much cheaper to treat a patient at an early stage with the aim of cure. That's also a priority for cancer treatment in Sri Lanka. This is the National Cancer Control Programme, and they have a clear objective around early detection of cancers, and there are some screening programs for cancers for patients in Sri Lanka. So we have undertaken a lot of work around whether there is a rationale to considering a screening program, a population-based screening program for kidney cancer. So why would we open that can of worms? This is a very emotive subject. Screening can be controversial. Well, it's actually because it's desired by patients and by doctors. So Sabrina Rossi, my lecturer, undertook a Delphi consensus statement with patients and with medical staff around the research gaps in kidney cancer. And one of the top areas that came out was a better way of early detection and doing that potentially through considering screening. So to cut a long story short, over the last 6 or 7 years, we've been undertaking a lot of work around what the rationale is for screening and whether we have enough evidence to consider undertaking clinical studies around this. The outcome of that work is that we've ticked off all of the checkpoints on the Wilson and Younger screening checklist, and we have enough evidence to proceed. So I'm going to tell you the results of the only clinical trial we're aware of around screening for kidney cancer. This is called the Yorkshire Kidney Screening Trial. It's a piece of work that I led from Cambridge, but with colleagues in Leeds, which is in Yorkshire, where we have some areas of deprivation. So it was quite a good area in which to undertake this screening approach. So the idea here was that as kidney cancer in the entire population in the UK has a relatively low prevalence, it's unlikely we'll ever have a standalone screening program. So the concept was trying to link screening of the kidney with another existing ongoing screening program, and we worked with colleagues who were developing lung cancer screening in the UK in order to have this combined approach. Smoking is the reason that people are invited for lung cancer screening, being a current smoker or an ex-smoker, and it's also the strongest risk factor for kidney cancer, so it made sense to look at this population. So in the Yorkshire Kidney Screening Trial, we aim to assess the feasibility of adding an abdominal non-contrast CT to the CT scan of the chest that's being done in the lung cancer screening approach. So this work was embedded in a lung cancer screening trial. We invited people between the ages of 55 and 80 to have this joint approach, and they attend a screening van like that you see here in order to have the scan. So we wanted to assess, would people take the offer of screening up? Was it acceptable to them and to healthcare professionals undertaking the screening? What were the proportion of people that were found to have a renal cancer? What were the stages of the disease that was identified? What incidental findings did we find, i.e. things that we didn't particularly want to find but would do as part of the process? And what serious non-renal findings did we identify, like abdominal aortic aneurysms and other cancers of the abdomen? So during the screening period, 4,500 people attended for lung cancer screening. The vast majority were eligible for our study, and ultimately 4,019 people accepted the scan and had it undertaken. So there was a very high uptake of 93%. There was a lower uptake among some individuals, those people that were older, women, and current smokers. We asked a subset of the group about their thoughts on the process, and these were generally very positive. So in terms of people who were satisfied, very high levels of satisfaction, only a very small proportion of people regretted having the scan. So here are the results and here are the outcomes. So 2/3 of people had a normal result of the 4,000 people that were invited. The remaining third were reviewed in a weekly imaging review meeting, which was led by a urologist and their team. Following that meeting, 20% of people had a letter sent saying that no further action was required because there was nothing of note seen. A small proportion were put back in contact with an existing clinic, and then 15% required some form of evaluation. About 5% went to a urology clinic, 6% to another specialist clinic, and 5% had a CT scan, a triple-phase CT scan, and further review in the urology MDT because there was concern about a urological malignancy. So here are the findings. So we split the findings out into serious findings, meaning those that were potentially life-threatening or had a possibility of reducing quality of life, or non-serious. 5.3% of all of the people we scanned had a serious finding. You can see here the things that we found. In terms of the most important findings, 1.5% of people had a new abdominal aortic aneurysm of over 3 centimeters. 0.25% of participants had a new kidney cancer. That was histologically confirmed. I'll show you that data in a second. And 0.25% had another different cancer in the abdomen. 2.3% of people had large kidney stones. So in terms of the kidney tumours, 1% of people were found to have a new renal lesion. There were a small number with an angiomyolipoma, 15 people with a complex cyst. There were 22 people, 0.55% of people had a new solid renal mass, of which, interestingly, after surgery or biopsy, there were a larger than expected proportion of people that had an oncocytoma. 7 people went on to active surveillance, so we don't have histology for those people. And then the 10 people, 0.25%, who had a definite kidney cancer because we either had tissue from biopsy or from surgery. In terms of the stages of disease, of all the people with a solid renal mass or a complex cyst, 3/4 were under 4 centimeters and therefore highly likely to be cured by surgery, ablation, or even safe to keep on active surveillance, showing that we do see a lower stage of disease in this group than you might expect in the general when we have sporadic referrals to the hospital. In terms of the non-serious findings, obviously these are a group of findings we don't particularly want to make because they aren't likely to be harmful to these individuals. 25% of people had an incidental finding. However, the key figure is that only 6% of people needed further investigations to define that this was a non-serious finding, meaning that we were able to reduce the burden on the healthcare service. So these figures of new cancers seem relatively low, 0.5% overall, 0.25% for new kidney cancers. So how does this fit into the other UK cancer screening programs? Well, actually, if you consider all of our serious findings, or the aneurysms plus the kidney cancers, and some of these aneurysm patients have had surgery and all are under surveillance, it is actually higher than other screening programs in the UK, such as lung cancer screening, breast or colorectal cancer screening. Even the proven cancer rates are higher than the bowel cancer screening program that we have running in the United Kingdom. So this is a summary of our key findings. This work's been published in European Urology, and we have funding for the next round of trials, which is a randomized trial to look at stage shift and survival, and that work's being funded by Yorkshire Cancer Research. So a key element is abdominal screening cost effective? And actually the work that we've led with colleagues at the University of Sheffield shows that yes, potentially adding a non-contrast CT of the abdomen to the chest CT scan done in lung cancer could be cost effective, particularly if we had a slightly tighter age range that we used, so we didn't go to quite as old an age range. This could certainly be cost effective. The combination of aneurysms identified and the cancers identified is very impactful. So just to finish and bringing back the title of my talk for you to consider, madness or brilliance. So we are getting positive signals so far. The next step, as I say, is a randomized controlled trial of abdominal screening in the context of people already being invited for lung cancer screening to look for stage shift and survival. The story might be different in countries like Sri Lanka, where there's a generally lower cancer incidence and kidney cancer is potentially less common. But I think what could be brilliance is the idea of adding on extra screening tests to detect disease early, whether it's cancer or other diseases, when we have contact points with patients and with the general public. And there are options around this, certainly around oral cancer screening, for example, in Sri Lanka. So I'll finish just by showing the names of the people who did a lot of the hard work on this, and thank you very much for listening.
Thank you, Grant, for that wonderful lecture and being here on this historic occasion. Thank you. we have a small token of appreciation for you. If you could come to the center of the stage, please.